So Module 5 is about barriers to implementation or revision of quality measures. Quality is about how you experience the world around you and how it makes you feel. That's it. That's all it is. If it makes you feel good, it's probably higher quality. If it makes you feel bad, it could still be pretty high quality if it's intended to make you feel bad. But ultimately, it's about your experience. I've been working very hard with the American Nurses Association on quality measures, particularly those quality measures that are captured in the National Database for Nursing Quality Indicators, because that's my portfolio for all intents and purposes. And what we do with that is try to assess this patient-sensitive, team-based, unit-oriented, a whole lot of hyphenated words there, measures of quality. And part of it's patients' perceptions, and part of it is nurses' perceptions. Part of it is just plain outcomes. So, and it's across the board of these structures, nursing hours per patient day, these processes, pressure ulcer assessment, and these outcomes, ventilator-associated pneumonias. These are all quality measures. And the reality of it is that quality is affected by humans, perceived by humans, corrected by humans, improved by humans, managed by humans. Human factors are huge in quality. And human factors influence what you perceive, how you perceive it, and how it matters. So, all right, one of your current perceptions is the top of this T-shirt, by the way. So it's, and I'm going off screen. Freud is my homeboy. Yes. So this was a gift to me from students in a death and dying course I took a long time ago, or I taught a long time ago. So there you go. Anyway, enough distraction. Let's get back to quality, which I think I just wrecked for this entire lecture podcast. So sorry. All right. So quality is about how humans interact, how their cultures interact with them, and what influences that. So why does culture matter? I'm a nurse. I'm a man. I walk into an Egyptian woman who's a Muslim and her husband isn't present. I can't do a whole lot with her until her husband is present or until a female nurse comes, because it just doesn't work with her culture. The perception of quality from her, if I am very respectful of that culture, is extremely high, regardless of the fact that I'm not doing the interventions that perhaps I should. Alternatively, if I walk into, and by the way, I've had many instances where I've had Muslim women whose husbands weren't present, and I had to very much limit what I was doing until he was present or get a female to do it. That's just the reality of it. Alternatively, I could be providing very, very high quality care without her husband being present, and her perception of quality would be miserable, because how dare I? So that's just the reality of it. You've got to consider the culture and where people come from. These quality measures that the NDNQI, for instance, CalNOC, the National Quality Forum, the American Medical Association's physician-centered Physician Consortium for Process Improvement. These are all quality measures kind of outfits, organizations that develop and capture what constitutes quality. And quality is about a lot of things. It's about the color, the texture, the placement of where you put things, sounds, smells. All these things affect people and how they experience their environment. If you painted and I've seen it, a psychiatric unit room bright pink, you're going to have highly activated patients. I don't know if it's going to influence their perceptions of quality, but it certainly influences the perceptions of the nurses and their perceptions of quality on that unit. Been there. St. Elizabeth's Hospital when I was faculty there. Quality managers will have a lot more success if they understand that human senses affect cognition, set alarms in people's minds, reassure success, and determine failure. Healthcare system is a highly complex organism, and it really is. It's almost an organism with multiple interactions where people, machines, processes all happen kind of together. Cognition and immediate responses to events are largely effortless and automatic, and humans build realities around these preconceived mental ideas from previous experiences, and they draw them from other events that are recognizably similar but not necessarily exactly the same. So if I had a really poor experience with a young, fresh out of school nurse starting an IV on my significant other, and it ended up with her getting stuck several times and then having to have the IV team come and try to start the IV, then the next time I go into the hospital with her and I see a young, probably fresh out of school nurse coming with an IV in her hand, I might just run for the IV team right away. So you build your history, you build your present, you build your future around what you know and what you've experienced. Flaws in recall are the distal and proximal causes for a lot of errors in decision making. Daniel Kahneman, who won the Nobel Prize for economics, which in it to itself is a really cool thing because he's a psychologist, proposed that there are two cognitive systems responsible for human responses. He termed those System 1 and System 2. He wasn't that creative with names, sorry. System 1 is this highly reactive, automatic system that is responsible for day-to-day immediate reactions to stimuli. 2 times 2, 4. You knew it exactly immediately, you didn't have to think about it. 17 times 43. Okay, that kicks in System 2 because you don't know it right away. Driving through your neighborhood. You turn left at a certain street, you just know it takes you down to your block, and from there you know how to get home. Driving in somebody else's neighborhood, you don't know, so you have to go into System 2. Even though System 1 fights and fights to remain in control because System 2 is just dead lazy. These System 2 activations, they're purposeful, they're activated, they require deep thought, and they're for challenging problems. System 1 is this heuristic, based on easily recalled, often very biased and poorly constructed models of reality. System 1 is very reactionary, and it is convinced that it is right. 2 times 5 has to be 10. We know it is, but System 1 tells you it is long before you actually work it out on paper, which you don't actually have to do. Now, System 1 answers such questions very simply. It knows these answers, and it's responsible for storing and memorizing such information. We remember these because we memorized them years ago. If we memorize them wrong, they remain wrong, but your System 1 remains convinced that they're right. System 1 is also responsible for answering other questions, like what color is the cap on the heparin vial? Hospital nurses don't have to ask this question of themselves, they just happen to know what it is. So if the vial top changes, it could screw you up for years. But because it's heuristic, it's got experiential bias, it is hugely responsible for a lot of human error. It knows it's correct, so it rarely asks System 2 to intervene. And I have to stop because I'm hitting